Thank you for that very kind introduction, Crispin. And I'd also like to thank the organizing committee for inviting me to present today. So really, I wanted to look at some of the new data, which is probably not that new, but probably the data that we do have probably poses more questions for us. And so the title of my presentation is a little bit misleading in the fact that I probably have more questions at the end of it than I did at the beginning. But hopefully we can get an overview of what we're trying to achieve as we go along. So today's presentation, is this working? Here we go. I'm looking at specifically a focus on beta-lactams because primarily that's obviously an area that I'm working in, but there still are workhorses in this country as far as empirical use of antibiotics. You know, in hospitals and where I work predominantly in my research and clinical capacity in the intensive care unit, we still use beta-lactams as our empirical cover, and we're still fortunate enough in this country to use it, say, compared to other countries where they're switching over to last-line agents. So really, we have been using beta-lactams for a wide period of time, but yet we have very limited data on how we can optimize them. And so really, our workhorses, we know very little about them, on how to optimize them, particularly in different settings. So really, I'm going to go through some of the aspects of the altered pharmacokinetics that Susie's touched upon, maybe a little bit more in the clinical aspect, as well as also the pharmacodynamic side of things. Obviously, the biggest pharmacodynamic marker we have with looking at how we dose optimize patients is the minimum inhibitory concentration, which is basically how we measure how effective our antibiotics are. But obviously, there's challenges with that as well. And obviously, putting those two together and looking at some of the strategies for dose optimization, particularly in the cohort of patients that I deal with in the intensive care unit, is something that we need to look towards doing, and this is probably where more questions and more research opportunities are coming about. And that'll probably be a final thoughts on where we head next. So we've already touched upon this before, and I don't want to go through it in too much detail, but essentially, where do most antimicrobial, or I dare say, drug doses come from? And that's obviously that pyramid there that you could see where obviously we develop it from animal species looking at the no observed adverse effect levels, and we build it up towards looking at and applying a safety factor that we determine human doses for. And obviously, that's trialed in healthy volunteers, and obviously we develop a marketing, or the pharma develop a marketing strategy based on that dosing in healthy volunteers. But what about the patients in hospitals? And we've already talked about this, so this is probably a little bit basic in our understanding, but we know that not all these doses that have been developed in marketing design and in the initial product information, it's not really appropriate for all hospital patients. And Susie's really touched upon this quite well, where she's talked about the different aspects of it, so I'm not really going to go through it in depth, so far as to say that I concentrate mainly on the critically ill patients in that group, but obviously we do have subgroups within that critically ill cohort or population. So we have obviously things like your burns patients that we look at, obesity being a very big problem, an epidemic, particularly in the developed and also developing countries now as well. Obviously a very important subgroup that we study in our critically ill patients. So there's pockets of patients that we need to obviously have data on in order to be able to look at dose optimization strategies. And so really, the concept of altered pharmacokinetics, something that I think most of you in this room would be aware of. This is really the textbook definition that I put up there, which is the study of the time course of the drug absorption, distribution, metabolism, and excretion, so the ADME, if you like. But in layman's terms, just to make sure that everybody understands it, it's what the body does to the drug. So that's just a basic definition of pharmacokinetics for those that might just want a refresher. And really, this slide is not for you to look at it and try to absorb everything, but it's trying to illustrate the complexity that we have with dosing in patients who have altered pharmacokinetics, and perhaps all the questions we need to ask in order to be able to determine whether or not a dose is appropriate from a point of view of safety, and probably toxicity is one of the things we think about as a pharmacist. That's something that I certainly do. But also, more and more, the challenges we have with making sure that efficacy is maintained in the climate of, obviously, accelerating antimicrobial resistance. So really, the patients that I look at, and a lot of my research is concentrating on, are those patients who come in with fulminant altered pharmacokinetics, so very dramatic pharmacokinetic changes that mean that we have to obviously look at responding with appropriate care, and obviously antibiotics being the cornerstone of that. So really, it's important to get that right within the first 24 to 48 hours if you have any chance of helping these patients who come in with sepsis or septic shock achieving a positive outcome. So Susie's touched upon the two different treatment modalities, the two major ones at least, that we use in the intensive care unit, which are obviously your renal replacement therapy, so your continuous veno-venous hemofiltration or hemodiafiltration, which replaces the kidneys, as well as the ECMO, which replaces the lungs and or heart as well. So really, these two treatment modalities, because they have out-of-body or extracorporeal circuits, they can cause a lot of changes to the pharmacokinetics, and quite dramatic changes to the pharmacokinetic profile of drugs that we feel, we think, oh, we can dose them quite effectively. What we've found is, no, there are actually quite big challenges in these cohort of patients. So really, looking at the initial changes, or taking a step back and looking at the initial changes when a patient comes in with sepsis, it's obviously the pharmacokinetics change, and that's as a result of not just the changes in blood pressure and fluid shifts from the intravascular space, so obviously the central compartment into the interstitial space, and so you get gross edema, and obviously that drop in blood pressure means we need to fluid resuscitate. So that obviously causes a gross shift and inward movement of fluid that we resuscitate the patient with, and that's particularly of note in hydrophilic antibiotics. So things like your beta-lactam antibiotics, are one of the things, aminoglycosides being another group of antibiotics that we need to be aware of when we notice this profound effect on the pharmacokinetics of these drugs. And this is probably a study that's been around since about 2014 when it was first published, but it's actually a good one because it's really looking at the antibiotic levels in intensive care units with a focus on 8 beta-lactam antibiotics. And really what this study was looking at the variability of these drugs and what reported exposure they had in these patients. And we have two graphs there. So we have graph A and graph B. And basically graph A is a sample of these 8 different antibiotics that were taken in patients who prescribed them halfway during the dosing interval, so a mid, if you like, what we call a mid, and just before the next dose was due, a trough. And what we noticed was that patients who had these samples done, and it was about 380 patients that were sampled in this study, there was a marked pharmacokinetic variability as displayed by obviously the interquartile range. And in some cases, it was up to about 500-fold variations in pharmacokinetic variability. So beg the question, what are the key components that we need to think about, what we call patient parameters or covariates, that are causing these alterations in this marked variability in the patients that we observe, not only in this study, but in clinical practice as well. And so that's obviously one challenge that we do have. And the other one that I'd like to switch over to is the pharmacodynamic side of things, which being in the intensive care unit, it's obviously sometimes maybe misrepresentatively so. It's labeled as the epicenter of antimicrobial resistance. But there's obviously some observational data that we have that maybe places that or puts the ICU in that frame. And this is a good suite of studies that were conducted in different countries. So it was in the Asia-Pacific region, in Turkey and in Germany, and they were called the COMPACT studies, and they looked at the in vitro activity of doripenem and other carbapenems against gram-negative bacteria isolated in hospitalized patients. And what they found was that obviously the aim was to look at the potency, but what they did also do was do a differential, and they looked at the MIC90, so the minimum inhibitory concentration that inhibits 90% of the isolates, and they compared it between the ones that were isolated, the bacterial isolates from the ICU versus the non-ICU, and they found that for the patients or the isolates that were from the ICU, they had a higher MIC. And in some cases, for meropenem, for example, it was 8 times higher. Imipenem, same as 8 times higher, and doripenem, which was probably not used as much, was also higher. So these are some of the pharmacodynamic changes we have seen and the challenges we have, because we obviously have organisms with higher MICs, and obviously getting to the point where we need to think about how we dose it together with the challenges of pharmacokinetic alterations in these patients. So really it's an uphill climb for a lot of the patients that we dose in the ICU, where we have to think about not just the pharmacokinetic changes, but also how well we dose them from the pharmacokinetic dynamic point of view, bearing in mind that we probably need to aim for the MIC breakpoint a lot of the time, even if we have a very highly susceptible organism, because we know that there's probably heterogeneity in the bacterial profile. So really this uphill battle means we need to think about what strategies we have for dose optimization, and it comes down to the pharmacokinetic pharmacodynamic index, or the PK/PD index that was touched upon in one of the keynote presentations this morning. And really, the 3 major ones that we use to describe bacterial killing can be grouped broadly into concentration dependent, time dependent, and concentration with a bit of time dependence. So what we say is the overall exposure. So concentration dependent antibiotics, so we look at the peak, and they have basically a post-antibiotic effect, because obviously we're looking at the peak and seeing that that correlates with the optimal bacterial killing. And the antimicrobial agents that correspond to that, or have a good correlation with that bacterial kill, are the antibiotics such as the metronidazole, aminoglycosides, fluoroquinolones, and lipopeptides such as daptomycin. As far as the ones that have an overall exposure point of view, it's the glycopeptides like vancomycin, the glycocyclines, azithromycin, and the polymyxins. And finally, the ones that, where my interest is, particularly in the beta-lactams, is ones that display time-killing dependence, so time-dependent kill. And that's basically the time above the minimum inhibitory concentration. That's not to say they don't have perhaps a post-antibiotic effect per se, but really it correlates well with the exposure of the antibiotic being above the minimum inhibitory concentration. And so really, what are the targets that we aim for? And this is where there's a bit of contentious data or conflicting data between what targets we should be aiming for the beta-lactams. So the early animal studies suggest that we should be aiming for 4 times above the MIC. And that really coincides with maximum bactericidal effect. And this data is just presented in one of the papers that was published in the Lancet Infectious Diseases. And it looks at being 4 times of the MIC at not the whole dosing interval, but a part of the dosing interval. So for example, for the penicillins, it's half of the dosing interval. You need to be 4 times above the MIC. For cephalosporins, a little bit more aggressive to 60 to 70%. And for the carbapenems, a little bit less to 40%. However, this doesn't really marry that well with some of the clinical studies. And there's probably because the clinical studies have a lot of heterogeneity, firstly. And secondly, to be able to recruit patients with less susceptible pathogens that we can look at thresholds for efficacy for beta-lactams are not easy to recruit. And often these patients who have that are often on synergistic or dual therapy, not just beta-lactam. So it adds the question of whether or not we have a really well-defined target in clinical studies. And what that results in is there's probably a bit of divergence, if you like, in what targets should be aimed for. There's obviously the school of thought that many might have heard from that has been promoted in clinical practice, where we aim for the antibiotic or the beta-lactam being above the MIC or 1 times above the MIC for 100% of the dosing interval, so throughout the whole dosing interval, versus looking at being a bit more aggressive and thinking about the fact that we have patients, particularly in the ICU, who might have a higher inoculum and might also obviously have pharmacokinetic alterations, which means that we probably have to look for a safeguard and aim for 4 times above the MIC. And so really these two targets are where we're at the moment in the literature. We don't know which one we should be going for, and obviously we're looking at ways that we can probably define that better, and particularly in which patients we should be aiming it for. Looking at those two different PK/PD targets for the beta-lactams, there was a nice study done by Belgium investigators in 2014 looking at doing a TDM-based dose modification. So what they ended up doing was actually doing a bit of sampling of the beta-lactams and sampling it at trough concentrations and looking at how they could dose adjust to aim for these different targets that we talked about. So they had this non-validated algorithm looking at adjusting doses based on what the exposure of the beta-lactam came at. So if it was less than 4 times the MIC, they actually increased the frequency to try to maintain it above that MIC, or switched, or increased the dose in some circumstances. If they hit what they thought was a sweet spot, so 4 to 10 times above that MIC, they had no action whatsoever. And if it was greater than 10 times MIC, they started to worry and say, oh, maybe we should be reducing the frequency because it might get toxic, even though we probably know that beta-lactams are relatively safe and have a wide therapeutic range. So what they did was essentially look at doing this and in a randomized controlled trial where they had about 40 patients, 20 randomized, or actually all patients had TDM done, but 20 were randomized to an intervention where they used this dosing algorithm, and the other 20 were actually blinded to the results of the TDM. So the physicians and the clinicians were blinded to the results of the TDM and just basically held steady and just decided to dose modify based on complete intuition. And what they found was that in the patients that, in day one, in patients that were they aiming for 1 times of their MIC, they found that in day one they were obviously similar, but when you got to day 3, there was a higher likelihood in the intervention group, unsurprisingly, because they obviously used this dosing algorithm to try to aim to get to a higher MIC, and they got to about, I think it was 95 to 96% target of 1 times the MIC. That was interesting because when they switched over to the alternate target of 4 times the MIC, which probably doesn't come out well on that, but it does here. So when they looked at 4 times the MIC and they looked at the day 3 results there, they actually found that it wasn't as easy a target to attain. And that probably reflects our clinical practice. Certainly when I try to dose adjust in the ICU and try to look at what targets I'm aiming for, typically getting to this 4 times the MIC is a lot harder. And I think that demonstrates to us the practicalities of PK/PD targets from a clinical point of view, that yes, it'd be nice to aim for higher exposure, but often trying to get there, particularly when you have a small window, step back, when you have a small window of day 1 to day 3 to try to get it right, it becomes increasingly difficult. And so really that is the ongoing challenge that we have. How do we try to expedite getting to these targets more effectively? And really using an unvalidated algorithm probably isn't very scientific, because we're using this very scientific approach that Susie's talked about of validating assays and using unbound concentrations and making sure we know what the quantitative side of things are, but then we take it and then we very much use an arbitrary dosing recommendation based on very little science. And so really, there has to be a better way of doing it, and this is where the potential or the opportunity for using a PK/PD model and dosing simulations can be utilized to what we call dose optimize. And really, this is a study that was done by Jason Roberts and Jeff Lippman, and it's probably one of many that you can pull out from those two that look at using simulation of antibiotic dosing to improve outcomes. And essentially, I'm just going to go through it with you step by step of how we perform these types of studies to look at developing a PK model that we can potentially use for patients at the bedside. So essentially, they looked at optimizing doripenem dosing in critically ill patients with nosocomial pneumonia who were obese or had this concept of augmented renal clearance, so creatinine clearance above 130 mils per minute, so obviously hyperclearing, hyperdynamic state. And the other challenge, of course, that we talked about, decreased bacterial susceptibility. And what that really involves for us from a practical point of view is obviously sampling patients, intensively sampling patients. And in this case, in this study, there were 30 patients that they intensively sampled. And they developed the characteristics of the drug exposure over the time course in these patients and found very important what we call covariates, so patient parameters that help describe the behavior of that drug in the patients. And the two biggest ones were, unsurprisingly, weight, considering that weight is correlated with volume of distribution, and beta-lactams being hydrophilic will distribute more readily than, say, your lipophilic drugs. And obviously how well they cleared. Again, being hydrophilic, they're predominantly cleared by the kidneys. So those two were found as the two most important covariates in these patients. And they developed a pharmacokinetic model where they used different dosing simulations. And before I get to that, I'll just talk about how they use different probability of target attainment using Monte Carlo simulation. So the two graphs, A and B, on your left are looking at a patient who has got a creatinine clearance of 100 ml per minute with different body weights, and obviously looking at the MIC as the x-axis and looking at the probability of target attainment using those different body weights in patients with a standardized creatinine clearance. The graph on the right is looking at a patient with a standardized body weight of 80 kilograms with different creatinine clearances, again, with different MIC distribution, and looking at the probability of target attainment using Monte Carlo dosing simulation. So basically, those were being used to help try to guide dosing in these difficult-to-treat patients. And then you go to the next step and look at how that can be used in clinical practice using different dosing regimens. So essentially, graphs A, B, C, and D are all different dosing regimens of doripenem in a patient who is 80 kilos, but with different creatinine clearances. So I think graph A is 30 mil, graph B is 50 mil, graph C is 100, and graph D is 150. So essentially, you're building what we call a dosing algorithm to help guide dosing in these patients that are difficult to treat because of obviously the pharmacokinetic challenges together with the pharmacodynamics. Time? All right. What the future holds and what we're trying to do in a clinical capacity is using this POP-PK model, which is here, and describing that model, which is basically through a study that you do in a patient population with intensively sampled plasma concentrations, and using obviously therapeutic drug monitoring of the patient itself to look at how we can use the Bayesian forecasting of the patient parameters, the individual patient parameters that you've measured, obviously their individual body weight and their creatinine clearance, and what the exposure of the drug is by sampling their plasma, together with this POP-PK model to help dose optimize or tailor dosing in patients that might be very difficult to treat. And this is something that we're increasingly seeing in our ICU. We have a patient who's on meropenem, maybe empirically, and they're, in this case not, but they may be, and they're 175 kilos, and they've got a creatinine clearance of 50 ml per minute. How do we dose that in these patients without trying to thumb suck and make it up? And so really, that's the challenge we have in the future. And I put this as a final thought, that we probably have more questions rather than answers, because firstly, as I illustrated before, we don't have a great deal of certainty of which pharmacokinetic target or PK/PD target we should be aiming for, whether it's 4 times the MIC or 1 times the MIC, or dare I say it, in between somewhere, depending on the patient. So that's really one of the challenges we have. The second challenge that we have is that we're thinking about plasma concentrations all the time, and we have this fixation on maybe unbound plasma concentrations. But we all know that most of our infections occur out of the central compartment in the tissue. So what is the exposure in the tissues of interest, the tissues that are being infected? And does that correlate with any of the plasma PK/PD targets that we're aiming for? So really, those are really two of the big issues that we have to look for in order to finalize or crystallize some of the therapeutic drug monitoring targets that we're aiming for beta-lactam antibiotics. And I suppose the last step is looking at how we can use a therapeutic drug monitoring program to look at some clinical or patient-centered outcomes. And that's probably the final challenge we have in order to looking at how we adopt it. So the title of my presentation was, What Data Do We Have? I think it's more about what data we need to go on to the future of trying to optimize these very important antibiotics. So thank you for your time.